Okay, we have a case submitted here for 3 implants. We'd like to take a look at these. This also is from a gentleman who was just recently at our seminar workshop, and let's take a look. So I've gone ahead and duplicated, I've gone ahead and sliced and locked in my window here so I can work. And the first thing I'll go back to is let's take a look and decide what type of guide we're going to use. And this certainly can be an OptiGuide. The OptiGuide will be dependent on 2 things. One, being able to get the SERIC data in, and 2, being able to verify that the SERIC data is correct. So here we can see that the SERIC data was able to come in, and then the issue will become whether or not CCAT will be able to verify that this data is correct. And based on here, again, it does look very correct. But CCAT has their own things that they'll take a look at. So let's start with number 19. What I'm seeing here, my first thing is that my occlusal plane seems to be off. What I'm seeing is that our occlusal plane is definitely tilted like this. So my question is does it have to be? So let's go ahead and try to make it correct. So there's a more correct occlusal plane. And then let's go ahead and bring that implant back into the center there. And as we do that, we can see that we're getting pretty close to the adjacent tooth, but yet still just far enough away. So in this case, I would see that I can't get it perfect, but I can get it pretty close without making it as not ideal as earlier. So if we take a look, here is your plan. Tooth number 19, we can see how big of a space we have, and my concern again on this is going to be the size of the cantilever and the forces placed on this implant, especially given that we've done not what we would consider a more ideal size for the molar. A more ideal size for the molar would be a 5.0 implant, and I can see why we didn't use that here, because in trying to stuff the implant in the bone that is available, we're going to hit into the cortical plate and possibly have implant outside of the box here. So they went with a 4.2. I certainly don't necessarily advocate that. I would be very comfortable doing some grafting in this particular case. So I'm not comfortable with the cantilever that's done there. So I would probably go ahead and do this. And then the next thing I would look at is buccolingually. I would first say that based on what I'm seeing here, our CEREC design may not be as ideal as I would like it to be. And by that I mean if we were to draw a line along the linguals of these teeth and the buccals of these teeth, we could see that buccally we're designed pretty well, but lingually it looks like we're quite thick, and there's a good chance that if this were our final crown that our patient would quite complain about that. Now if we were to knock this portion of the crown off, we could see that our implant would actually be placed quite to the lingual of our restoration. So again, this goes back to the concept of the principle that I harp on of making sure that our implant or restoration design is accurate, and then again accurate in terms of also the size of it here. So I would say that actually our tooth probably needs to end about right here. So we are definitely a little bit to the lingual. So I would go ahead and move this right here to the buccal, and then I would go ahead and tilt this out just like so to give us a better emergence profile there, like so. Next thing I would have questions on are the bone level position. Here we can see a couple of things. One is if we look at our emergence comes straight out, so that's usually not typically what we want to do. So the implant would need to be placed deeper, but the real problem here is actually the manner in which we drew our CEREC margin, which would also indicate why we got such a big CEREC proposal. It's unlikely that we're going to design a restoration that looks like that. If we were to just take a look at this, I would probably make a correction that our margin really needs to be probably right in there somewhere. So when we draw our circle, we need to draw it based on where we want the emergence to come out at. So again, this implant I think can be placed up like this. Personally, I would go to the 5.0 implant, and I would just go ahead and graft this little bit of area here at the time of placement. We are close to this adjacent tooth here, so if anything, we could cheat a little bit more, and now we've gained some more of that space back, and we maintain that implant in the center. So if we take a look at our loading forces here, here is my plan. You can see how this looks more to be in line with the arch compared to your plan that you submitted, and here we can see that looks to be tilted out to the buccal. Okay. And I still think that this plan is, based on what we're seeing here, to the lingual, compare it to these adjacent teeth. So I would probably go ahead and move that out a little bit more and just graft that site. Let's go ahead and move on to tooth number 29, we'll call it. And again, we have the same types of issues here. The first thing that sticks out to me in looking at this is that our access is going to be on the distal side of the tooth. We can see how much more space we have here on the mesial. So I would definitely want to correct that, and we can see our occlusal plane is also incorrect. So, and I know exactly why we did that, and in this case we're going to have to do it because as we correct the occlusal plane, we get closer and closer to the adjacent root because of the curvature of the root. So in this particular case, we're going to need to do that, but in doing that, I would go ahead and tilt this implant to the mesial to make sure that I at least get my screw access through the center of the tooth. Again, I'm okay with the 3.7 here. Ideally, I'd like a 4.2, but we can see on the buccal lingual, I don't like to be engaged into the cortical plate up and down the entire implant. I think this is more of our ideal position, and again, this may require just a hair of grafting at the time of placement, but nothing that can't be done pretty predictably. Again, the only other thing I would look at here is, again, it looks like we're tilted out when typically these teeth are tilted in. So I tilted to the lingual, so I might actually tilt that in and then bring it out a little bit more to the buccal. So again, I'm just trying to give us more of an ideal position based on the data that we have. And then we can make clinical decisions. Again, I think a little bit of grafting in this area is quite predictable, and I wouldn't be overly worried about that. I would definitely want to do something more like that. Now, if we go ahead and move over to number 30, we'll see this again based on the resorption pattern, based on what I've seen. This is also going to be in the same situation. The occlusal plane, as we can see, is definitely a little bit up. So I would go ahead and correct the occlusal plane on this one, like so, and then bring it over. And then the question is, are we too close to that adjacent implant? And it looks like we have a requisite 1.5 millimeters of space there. So at least with this implant, we can try to get it more level with the occlusal plane, and then we just need to work on the angulation. And here, as I look down the line, you can definitely tell how that is tilted out there. So, and we can see why. So let's go ahead and bring that in and bring that to a more ideal position, like so. Now again, this is outside of the bone certainly, but something that can certainly be managed with just a little bit of grafting at the time of placement. Now, some may not like to place this implant at this angle compared to that tooth, so if that were the situation and you wanted to be a little bit more angled, certainly I would accept that as long as I can try to get my screw access into the center there. So hopefully this helps. My suggestion would be to plan on grafting this at the time of placement. I would certainly have this looked at more closely in terms of, is this truly integrated? My guess would be there's a good chance that CCAT will say that they cannot verify the guide because of the amount of scatter that's there, and they may suggest using a classic guide technique with the bite plate. Thank you for submitting the case, and hope you have a wonderful day.